welcome all of you, and and I look forward to getting educated. My pleasure to introduce Dr. Ramaraju, who is an extremely well-known name in the field of fertility. Uh, and he is the founder and medical director of Krishna IVF. He's also the honorary professor of biotechnology at the Andhra University at Visakhapatnam and the adjunct professor of Department of Reproductive Medicine at the Ramchandra University, Chennai. He has many publications to his credit, and he's also extremely a good clinician, and as all the couples who go to him will stand testimony to the time and effort that he spends with all of them. So with those few words, I hand over to Dr. Ramaraju for his presentation.
Thank you so much. And I move now to Dr. Ramaraju, who's already been introduced. And thank you so much for being part of this wonderful seminar. I know him on a personal level for many, many years, and I think he's the most humble person I've ever met in my life, being with such vast experience, such vast knowledge, but he comes across as a very, very down-to-earth and humble person. So, Dr. Ramaraju, the stage is all yours, and we would like you to start your lecture. Thank you so much.
Are you able to see my screen?
Yes, sir, we can see your PPT. You can continue with your talks.
Yeah.
So just open the PPT, sir. Yes.
I thank the Royal College of Obstetrics and Gynecology, the Indian division, and especially Dr. Swapna and Dr. Uma for inviting me to share some of these thoughts on the endometrial assessment. And in this talk about 20 to 25 minutes, I thought I will move more than what I was briefed about to speak a little more about endometrial receptivity rather than endometrial assessment in the area of assisted reproduction. What is endometrial receptivity and why do we check it? The endometrial assessment in assisted reproduction, we check it to see whether the endometrium has the ability to allow normal implantation. And that is what we all do throughout our reproductive career. Our goal in this field is to produce good quality eggs, good endometrial bed, and good quality embryos, transfer them and produce healthy life spring. And in the area of endometrial assessment, it has become more and more important in the last 1 decade. Apart from looking at endometrium, it has moved beyond that field. In the earlier years, just giving estrogen and progesterone has helped us to produce viable offsprings in the oocyte donation program, and that made us feel just giving progesterone after estrogen is adequate. But as years went by, we realized the 5 days of progesterone, or also known as the area of window of implantation, is not as simple as we feel, and the area of implantation or the window of implantation, it was all along assumed it's a constant thing, but now there is a lot of evidence from the genomic information that there is a displacement of the window of implantation by up to 25%, and there you can have a delayed window of implantation, or an advanced window of implantation, or a shorter than 5 days window implantation. And we try to assess endometrium to look at this window of implantation. And one of the tools we use routinely is ultrasound, but there's more than that. In endometrial assessment, endometrial receptivity is one part, and the journey for endometrial receptivity has started, to be precise, more than 95 years ago, when you have the Samson theory of retrograde menstruation. Then you have the George Seeger-Jones work on the luteal phase defect in 1949. Then you have the Novus criteria in the mid-50s. Then the discovery of the pin ports in the 70s. Then the discovery of the estrogen and the progesterone receptors between the 80s and the 90s. Later, between 90s to 2000, the Spanish group were able to identify endometrial receptor genes. And as we move forwards, we are moving into multiple areas of assessment of endometrium, either through the imaging, the molecular thing, which can be through the genomics, through the proteomics, and the metabolomics. And the final word about the ideal tools to assess endometrial receptivity has not been said. The reason to not to be able to say the ideal tools is looking at the endometrium and assessment of it, we are unable to assess the implantation of the embryo because it contains multiple steps which involve apposition of the embryo, addition of the embryo, and then invasion of the embryo into the endometrial cavity to produce and progress the pregnancy. As you see in the next diagram, there are complex events which are involved at different stages, be it at the apposition point, wherein you have this set of hormones, then you have the steroid hormones, then you have the messengers. Then as you move to the addition, you have the vasoactive factors which make a difference. You have the chemokines, then you have the addition molecules. Then as you go to the invasion part, you have a whole set of chemical messengers, which in our undergraduation and post-graduation, we had very little time to go through, and most of this progress has happened in the last 10 to 15 years. So the tool to identify these processes, the endometrial assessment, has become much more broader, and this is what I'm going to talk about. The range of receptivity problems or failure of the endometrial assessment problems, as you can say, can be an implantation failure, complete implantation failure, which can present as infertility, a deficient implantation where it can present as a miscarriage, or a mild abnormal implantation and invasion, which can present much later during pregnancy as preeclampsia. So the scope of the problem of the endometrium as an important marker, which as an important area of subject, we as reproductive medicine have ignored it for the last 3 decades, and now we have started looking at it and then realizing it's not an inert substance and it's a dynamic process. The causes, as we describe superficially, can be described as a defect in the endometrial assessment or receptivity can be caused by endocrine causes, inflammatory causes, fibroids, polyps, septae, immunological mediated disturbances, and not but the least is the emerging field of the microbiome. What are the tools we have to assess the endometrial assessment? when we say endometrial assessment, we always think about the ultrasound, or at the most, we think about the histoscopy. But there are a whole lot of parameters that have come in. In the ultrasound, you have the endometrial thickness, the endometrial volume, the endometrial pattern, the endometrial blood flow, and the endometrial contractions. These have given some amount of information, but their specificity in terms of saying this endometrium is good and will be able to receive the embryo for a good implantation is not specific. Then we have the emerging area of junctional zone, which for the last 40 years and the effort of Bronson by his repeated publications, he is trying to highlight the area of junctional zone, but its importance is more coming into forefront. Earlier, you can see the junctional zone only in the MRI. Now you are able to look at on the 3D ultrasound. The histoscopy has gained widespread information, but I feel they're only looking at histoscopy as going into the cavity and looking into the cavity for any morphological or structural abnormalities, but we are not paying enough attention to the visual appearance and then follow them up with a specific area of biopsy to identify subspecific abnormalities. If you look at the way a colonoscopist looks at the colon, we should start looking at the histoscopic evaluation as a colonoscopist looks the colon and then do a directed biopsies. Then in the area of natural killer cells, it has become an enigma, and the endometrial receptivity tests have made us understand a little more than what we knew a decade back, but still a lot of things have to come. And the most important thing in the emerging field is the microbiome, which will change the way we practice in the next 1 decade. A few words about endometrial thickness. A thin endometrium is probably the morphologic expression of a defective vascularization during the invasive phase, and it alters the implantation. But how it alters the implantation remains unclear, and there are a host of treatments that are available, be it estrogen, the aspirin, the sildenafil citrate, the pentoxifylline, the vitamin E, and the intrauterine granular choline stimulating factor administration. All of them are isolated reports. They are shown to be effective, but in the real sense, they are not very effective. The reason is we fail to understand the interaction of the embryo and the endometrium is a dynamic process, and it's a multifactorial process. Till we unravel those things, the treatment of thin endometrium will remain an enigma. Now, when I come to the junctional zone, this is one parameter which most of us can incorporate into our practices, and I'll share some of our work which we did in the last 5 years along with Samson. To have a good pregnancy, we should have a good sperm, a good oocyte, a receptive uterus, which in this case I'm saying a good junctional zone, and a proper transfer of the embryo. We fail to understand that junctional zone and placentation are important, and there's a crosstalk between the embryo and the material thing at the time of the implantation. The deciduum in the junctional zone forms a functional unit that largely determines the likelihood of successful pregnancy outcome. And the trophoblastic invasion of the deciduum and the junctional zone, which forms the placental blood is not only interstitial but also intravascular. So that's the area we should start looking at and read the articles that are coming forward in the area of the junctional zone. We published our work 2 years back in the International Journal of International Society of Ultrasound, ISUOG, where in this work we try to build a model of predicting implantation success using junctional zone assessment in assisted reproduction. In this work, what we did was we did the junctional zone assessment of the uterus in all the 3 planes as shown in the figure. On the right side, the fundus, and the lateral side. And then we did it on every alternate days throughout the cycle. And all the 3 planes, the red line reflects the non-conception cycles and the blue line reflects the conception cycles. This work has shown that junctional thickness measured at the fundus, right and left, show increase during the stimulation cycle. The average rate of growth is around 0.16 millimeters per day, and junctional zone in the pregnant group is significantly thinner than in the non-pregnant group from day 3 to the day of the oocyte retrieval. This junctional zone change throughout the stimulation cycle and growth is different in pregnant and non-pregnant, and the junctional zone assessment is also a predictor of a good implantation and a pregnancy rate provided your embryo is good. This is the evolving area. How do we measure the junctional zone? We take a 3-dimensional view, then we measure at the midpoints at the fundus, the right, left, and the left, and the average measurements we see is between 1 to 3 millimeters. And when the junctional zone measurement crosses 3 millimeters, we are having a decrease in the implantation compared to the pregnant and the non-pregnant group. So this is another marker that is coming in to say that the ultrasound is not lost. Many times we just look at the endometrium and say a triple line, but we might have a triple line but can have an abnormal junctional zone. In this, as we are doing the stimulation protocol, as the woman visits the gynecologist, along with the follicular development, we started doing the endometrial junctional zone assessment throughout the cycle and then plot them to do the prediction. And in this graph, you see the blue color is the non-pregnant group and the red color is the pregnant group. And in endometrial thickness, you hardly see any difference between these 2 groups. So endometrial thickness may not be a predictor of implantation. Whereas when you come to the junctional zone, the blue is the non-pregnant and red is the pregnant. And these are the measurements of the junctional zone from 1.8 to 3.8. And you see a clear marked difference of the change in the junctional zone throughout the cycle. The red line, which is the implantation group, showed much lesser junctional zone compared to the non-pregnant group. There was one more work that has come from Brazil in this area, but they studied only on the day of the HCG, the junctional zone between the conceived and the non-conceived. And they also showed a cutoff level of more than 3.5 junctional zone size as a less probability of non-implanting, but more work is to be done in this area to become these findings to become robust. So this is the same thing at the fundus area, on the right side, on the left side, and the average thickness. And it's a promising marker which we are using in our clinic. And once we have numbers in hundreds and closer to 1,000, we will come back with a bigger publication. This is how the junctional zone can be measured. And so junctional zone is an important tool, and I would like all of you to look at this thing because it is not difficult to do it, and which is practical. And with time, it will become a good tool of endometrial cavity assessment and implantation assessment. The second area which we are having a lot of enigma in the last 10 years is endometrial receptivity. Earlier, it was the endometrial biopsy, be it the luteal phase defect or the novice criteria, where the emphasis was whether progesterone was acting on the endometrium. And apart from saying progesterone has an important role, we have not completely understood the other two concepts. The progesterone action on implantation has a multiple role of action, and then you have this family of genes which is essential mediators of the progesterone receptor action on the uterus, and expression of this factor is crucial in mediating the communication between the uterine epithelium and the stroma required for implantation. They also promote downregulation of the endometrial receptors in the endometrium, which should happen before the implantation happens. So progesterone has an action through this hedgehog family in downregulating the endometrial receptors on the endometrium before the implantation happens. One word of caution, which we never give importance is, which is apart from the main topic, is what is adequate progesterone level on the day of the embryo transfer. Here is a good study which they identified when somebody is giving progesterone during the luteal phase support, and these are the 5th percentile and the 95th percentile of progesterone that is given in a frozen embryo transfer cycle, and a progesterone value on the 5th day of progesterone of 9.2 and above has a significant impact on the implantation. We never look at this value, but keep on pumping progesterone through the oral route, through the intramuscular route, and the vaginal route, hoping that we are given adequate levels. And in this work, we have this group of scientists have identified a 5th percentile and a 95th percentile of the progesterone levels that are needed to get a good implantation, and any level more than 9.2 nanograms on the 5th day of progesterone is adequate. So you did not pump in a lot of progesterone, but verify whether your progesterone is adequate so that the changes on the endometrium are there to make it ripe for the endometrium. One important thing which we fail to understand is, if we have levels here around this thing, then we can say a progesterone deficiency. But this is different from a concept called progesterone resistance. Progesterone resistance is not the same as progesterone deficiency, and there is an organic and a systemic disruption of the action of the progesterone, and a defective and a graded response to progesterone, which is predominantly seen in the area of endometriosis, endomyosis, and this can be caused by this handful of genes which will alter these areas, so in the process impair the implantation. So always remember that there are two words. One is the progesterone resistance, the second is a progesterone deficiency. Most of the time we confuse between these two things. Progesterone resistance is related to endometriosis and also to endomyosis. That's an important evolving concept that is coming in the last 5 to 7 years. When we come to endometrial receptivity tests, there are primarily three groups of tests, which one is based on assessing the integrin values, and this test is used by the AL group, and this is predominantly used in the area where you are looking at an endometriosis, hydrosalpinx, and in a subset of unexplained infertility and unexplained recurrent pregnancy loss. In this group, in hydrosalpinx, if you are in a doubt whether to do a surgery or not to do a surgery, using this parameter, if it is elevated and you correct it, this value comes down. Similarly, in the area where you have repeated implantation failures in endometriosis, assessing the integrin alpha B3, if it is elevated, then it might have a role of correcting the endometriosis in repeat IVF failures, provided you have adequate antral follicle count. The endometrial receptivity array explains whether the window of implantation is accelerated or delayed in the luteal phase differentiation. We think endometrial receptivity array gives all information about the receptivity of the endometrium. It only gives the effect of progesterone on the endometrium and whether the genes that are related to progesterone adequate levels are upregulated. Then you have a positive endometrial receptivity array test. If it is not upregulated, then you have a negative endometrial receptivity array test, wherein you tinker with the dose of the progesterone and the timing of the embryo transfer to overcome that. One should remember, endometrial receptivity array tells one facet of the endometrial receptivity in relation to adequate levels of progesterone on the endometrium by the time the embryo is placed. So that's the reason in endometrial receptive array, the solutions are the shift in the timing of embryo transfer must be used. That's the reason, because you are trying to identify the action of the progesterone on the endometrium. There is again another test which is consists of B6L6. This is being used again in the area of endometriosis, and if the BCL6 has high expression, that is where you can do in a subsequent cycle a GnRH agonist to suppress this BCL6 or surgery before endometriosis. All these tests are evolving and they look at different facets of the problem, but all these receptivity tests do not check the same thing. Each of them check one particular aspect. So a word of caution is needed when we look at the information of the endometrial receptivity tests. The biomarkers that are currently being studied for the development of further markers are as follows. They are integrin, selectins, MUC1, cytokines, growth factors, laminin, cathedrin. These are the things. And in future, you will have a host of endometrial receptivity array tests. The most important thing that has been coming forward between 2015 and 2020 is the era of microbiome in the whole reproductive system, in the whole human being, be it in the area of gastroenterology field, be in the area of reproductive field. For many years, it was thought uterus is a sterile environment, and it has been proven that uterus has its own microbiome set of organisms which facilitate the adequacy of the pH and the oxygen tensions in the microenvironment. The vaginal and the endometrial microbiomes has been implicated in implantation failure. A severe form of this is the chronic endometritis. I'll come to the chronic endometritis. We always look in India only for the tuberculosis-based chronic endometritis, but the non-tubercular chronic endometritis is found in 30 to 60% of patients with repeated implantation failures, as published in this work in the year 2014. So look at endometrium from an infection point of view. How do you identify chronic endometritis? In the endometrial biopsy, if you see 3 or more plasma cells which are detected by immunohistochemistry for CD138, that shows that the endometrium has endometritis. The other way is they do the gene sequencing of the type of microbiomes that are present in and assess the amount of lactobacilli compared with the normal things. The third area is in histoscopy, identifying and looking for strawberry appearance or micropolyposis, which also shows that the endometrium is a seat of endometritis. This is a close-up view of the endometrium where you see micropolyps. The findings in an endometrial infection can be: one is presence of micropolyps, focal or diffuse hyperemia, which is seen as a strawberry isolated appearance, a polypoid endometrium, and an endometrial edema in the follicular phase. When you look at this, prefer to do a directed biopsy of that particular area and discuss with the pathologist to do the immunohistochemistry to look at plasma cells to diagnose chronic endometritis. The uterine microbiome contributes to healthy endometrium, and this colonization will have an impact on the steps of endometrial physiology as seen in this diagram, wherein if this colonization of endometrium is disturbed, then blastocyst implantation and healthy placentation may not happen. It affects happens to this group of molecular messengers. So in the area of implantation, where does microbiome has a role? The areas where it has a plausible impact is at the interaction of this receptor expression level, at the epithelial permeability, and also at the area of NK cell. This is an evolving area, and in the next couple of years, we'll have a lot of work that is coming in through the use of the omic technology, which will speed up the process. The current protocol for an ART failure to look at endometrial assessment is, apart from a 2D image, you do a 3D image to look at the junctional zone. You do a histoscopy to look at the cavity and look at whether there is any edema in the proliferative phase, whether there is any strawberry appearance or micropolyps. If none of them are there, the possibility of having an endometrial pathology or a cavity pathology or implantation pathology is less, so you go ahead with it. If there's a pathology, treat it. When you use a receptivity array, if the endometrium is receptive, then it says to a large extent the bed is fine, but it's not 100%. But when you have a non-receptive endometrium, we know the window of implantation is disturbed depending on the type of test you use, and the treatments at this moment are only adjusting the window of implantation. But with time, future diagnostic modalities and therapeutic modalities will come in to solve at this area. So the black box at the area of implantation is trying to open up into different dimensions. And in the next slide, we are seeing this is what is going to happen in the next 5 years. like the way you are checking the pre-implantation genetic diagnosis for the embryo, you will be also looking at the omic technologies on the endometrium to look at either by proteomics, metabolomics, or genomics, or by mRNA to identify the optimal endometrium. And here, at this moment, most of the assessment is happening by biopsies. But now, a couple of publications are coming in where they're trying to aspirate the minimal fluid that is present in the endometrium just before the embryo transfer so that the endometrium is not disturbed, and in the same cycle the embryos can be transferred. We are in an era of exciting change in the field of reproductive medicine, wherein genomics, proteomics, metabolomics, imaging combined with artificial intelligence is making this field a wonderful field, and there can't be any better time to be in this field than at this period of time. So this is a diagram of changes that are happening at the DNA level, at the RNA level, at the proteomic level, metabolomics. This combined with the big data analysis will make our field much more evidence-based, much more specific, and much more protocol-driven process in the coming years to come. I thank you for the hearing, and I'm open for the questions.
Thank you very much, Dr. Ramaraju. As always, your lecture is always very thought-provoking and lot of introspection. There are few questions which are coming in, and one of them is that even despite doing ERA, if you do the embryo transfer according to ERA and it fails, what else could be done for such a patient?
We have never understood the ERA test properly. ERA test is designed to see whether adequate progesterone has happened in the area of window of implantation, but it does not address the addition component of the embryo implantation and the invasion component of the embryo implantation. So it has only told one facet of the whole story, and we are trying to look at whether we are putting the embryo at the right time. That's only one information should take it from ERA. But a failure of ERA test will not say, if the ERA test says a normal receptive endometrium, it does not mean the receptivity is perfect. Its relation to the progesterone effect on the endometrium is adequate. It does not say anything about the embryo or other facets of the endometrial implantation.
Okay. There's another question about measuring the serum progesterone levels on day 5 of progesterone, P+4. If it is less than 9, how can you rescue the cycle?
Basically, what happens is we never looked at the bioavailability of progesterones and never had values of progesterones. And I request our society leaders to do a study to have nomograms of the progesterone of different products, and it saves the patient huge amount of medication because we end up giving through all the possible routes the endometrium to the woman. These are one of the few things our society, if it does it, it makes a huge difference of producing nomograms. I don't think no society in the world comes out with nomograms in relation to patient care. They give guidelines. As a leader, I request you to do so, and my full support for that endeavor will be there.
Thank you so much, Dr. Ramaraju. I think you always give some food for thought. With this, I thank you very much on behalf of the society and the AP group of RCOG, the South India group of RCOG. As always, a very, very thought-provoking lecture. Thank you so much.